Cos'è questa mimica facciale? Questa mimica non è una cosa che ti fa bene al pancino. La bua. Non va bene. Abbiamo un biscotto tuo? È una cosa che ti fa bene al pancino. Un po' di te. La bua. Non va bene. Abbiamo un biscotto tuo? È una cosa che ti fa bene al pancino. Un po' di te. La bua.
Just see the coma see. Just see the coma see. Just see the coma see. Morning, Coma. Thank you.
Good morning.
Fantastic, Professor Chatterjee and Mahapatra are here, and
Good morning.
thanks. And is Professor Rajashekar here?
I'm not seeing him.
Could you just text him for me, please?
I'll do that.
Thanks.
Hello.
Expecting, he was wondering there what's this thing, maybe some miscommunication. I'll send it right away, sir.
Oh, thanks. Thank you.
Oh, that's also Zoom.
Sorry, Komal, not hearing. Hello, Komal, couldn't hear.
Yeah. Oh. Okay.
So, Professor Chatterjee, the morning chairs will be Professor Rajshekar and Dr. Komal Prasad. And we'll
Fine,
just
great.
Hello, Naren.
hello.
Hi, Komal, how are you?
Yeah. Hi, good morning, sir. So Professor Rajshekar is busy in another Zoom meeting, so he has excused himself.
Yeah, I was in that meeting as well. I
Oh.
just finished that and came through. I think he's finished by now.
Not yet. It will take another half an hour, so he just excused himself.
Okay,
So-
don't worry. So we'll start in 2 minutes. So Komal, we both can alternate, and you can introduce Professor Chatterjee, then I'll introduce Professor Mahapatra. Okay.
Sir, what's the schedule time for this?
We'll be starting in a minute.
So he told me that he will join at 1:30.
Who, Professor Mahapatra?
Yes, Mahapatra, sir. Yes, sir.
That's fine. The first talk is with Professor Chatterjee, so it's Professor Mahapatra is in half an hour's time.
Yeah. So he will be joining within 15 minutes, I think. So he told that he will come at 1:15.
Okay.
The meeting will be scheduled at 1:30.
Okay.
Anyway, I'm informing him, sir.
Yeah, his talk is in half an hour. Great. Good morning, everyone from around the world. It's great to have you back again for this second day of the International Pediatric Neurosurgery webinar course. We had a fantastic day yesterday, and today we have again eminent faculty with the great topics to learn and to discuss. It is my pleasure to introduce my co-chair for the moment. I will be co-chairing for the moment, but it's Dr. Komal Prasad. He's a senior consultant neurosurgeon at the Narayana Health in Bengaluru. And today's program, we have got Professor Chatterjee, Professor Mahapatra, Dr. Tomal, and Dr. Timbaba Hegde. So we have got a fantastic lineup today morning. If I may ask the participants, if you could please keep your mic muted at all time. And also, if you have any questions, please put them on the chat box and the chairs will read it out to the speakers. This way that we can keep on time, and also if the time runs out for the speakers at 30 minutes, they can generously answer the questions on the chat box. So I'll now invite Dr. Komal Prasad to chair the first talk. Dr. Prasad.
Thanks. Thank you, Naren. Welcome, everybody. Hello. And after a wonderful session yesterday, we are continuing the second day of the webinar course, which has been going very smoothly from yesterday morning. And welcome to the second day of this program. Today's first talk will be by Professor Sandeep Chatterjee, Senior Consultant Neurosurgeon from Calcutta Park Clinic. He conducted the ISPN meeting just recently in earlier part of this year, and probably that happened to be one big last meeting this year. After that, most of the meetings got cancelled because of the pandemic. Professor Sandeep Chatterjee will be speaking on spinal lipomas. Over to you, Dr. Professor Sandeep. Yes, sir.
Hello. Good morning or afternoon to wherever you are in this part of which part of the planet you are happening to reside in. I have been asked to talk about lipomas in children. I hope you can see my screen, Narayan.
Yes.
Yes.
Yeah.
Yeah, perfect. Okay. And probably it is one of the not so easy subjects to speak on in pediatric neurosurgery. I thought I will divide my talk, for which I've been bestowed 30 minutes, talk a little bit about the origin, the presentation, the investigations we do, the treatment decisions we make, and then if time permits, we'll go through the details of technique of surgery, complications, and mention a little about follow-up. Where does one begin? My favorite Julie Andrews film and the favorite song, let's start at the very beginning. You know, a very good place to start. You know, when you read, you begin with ABC. When you sing, you begin with do, re, mi. But when you do pediatric neurosurgery, then you start with embryology. And that's what pediatric neurosurgeons consider to be the start. So here's just reminding ourselves of how the spinal cord develops. And it develops by three fundamental processes. A process by which you get a three-layered embryonic disc, which is termed gastrulation. A process by which the neural folds join together and form a neural tube called neurulation. And finally, a process by which this neural tube separates from the skin, so the cutaneous and the neuroectoderm have a happy parting, a process called disjunction, and the space in between is occupied by mesoderm. So what we're really interested in today when we talk about lipomas is the third of these processes, the process of disjunction, the separation of the neural tube from the cutaneous ectoderm, and how it goes wrong in a lipoma. Very simply understood, this is disjunction. If C represents cutaneous ectoderm, NG, the neural groove, and N, the neural tube, well, that's what it's like first before the tube closes. And then the tube closes, you get a neural tube, and you get a cutaneous ectoderm. And then this neural tube separates from the cutaneous ectoderm, and this separation is called disjunction. However, sometimes things don't happen to plan. And if you have a situation, so when you have disjunction, as I told you, this cutaneous ectoderm and the neuroectoderm are separated, and this is occupied by mesoderm. And that's what it should be. But if the neural tube were to separate before it's closed, then you have a situation like this, where an open neural tube moves away from the cutaneous ectoderm And this mesoderm, which should have come in between with the neural tube closed, now comes and sits like the ice cream on an ice cream cone on an open neural tube. And what that produces is a situation like this, where you have cutaneous ectoderm, neuroectoderm in a neural tube which is opened but now covered by mesoderm, and that's what we call a lipoma. Right, simple. So when we think of a lipoma, this is what we think. A layer of cutaneous ectoderm, marked C, a layer of mesoderm, which causes the cutaneous ectoderm to bulge out, and a neuroectoderm below in a neural tube that has not completely closed, but has a clear demarcation with the mesoderm. The demarcation being the famous white line that Professor Peng introduced us to. So this is what we look at when as pediatric neurosurgeons, we look at a lipoma: skin, mesoderm, and a neural tube. When you have the MRI, that's what you're looking at. You're looking at skin, you're looking at mesoderm, you're looking at the neural tube, and you're looking at the mesoderm that has come between the skin and the neural tube to produce this lump and lift the skin up. So whereas on an MRI, you see all sorts of things, we see cutaneous ectoderm, mesoderm pushing the cutaneous ectoderm up, and neuroectoderm. And that's what it looks like when you see a lipoma in real life. So from now on, when you see this, this is what you think. How do they present? Again, if you have a cutaneous ectoderm, then they can present, they always have intact skin. Remember, the cutaneous ectoderm is intact. The mesoderm produces a lump. This lump can be soft or firm, depending on the nature of the lipoma, but it will not be cystic because there is no fluid there. It's fat. And finally, because you have an open neural tube into which this mesoderm is forcibly insinuating itself, you may have a neurodeficit. Again, very simple once you understand the embryology. And they present with a midline swelling like this in the back. The important thing when you see a midline swelling is, of course, to ask how long it's been there, to see whether, to find out from the parents whether it's increasing in size. The question we like to ask is whether it increases in crying, whether there is pain, very importantly, whether there is a discharge or whether there is a sinus. And oftentimes you have to investigate a little below that lump, and there's a little sinus, and I'm going to tell you a little bit about this sinus because it's very commonly found if you look for it. But this sinus is below the third sacral vertebra. A sinus which is below the third sacral vertebra is not a dermal sinus. So this is in fact a postanal pit or a postanal dermoid. And the treatment of a little sinus like that below the third sacral vertebra is supervised neglect. Right. You don't only look at the lump, you look at the patient as a whole. And of course, it's very important to look at the faces, look at the other general features, and of course, very importantly, to look at the trunk to see if there is a spinal deformity. And of course, this particular child, as you can see, also has a lipoma up there in his forearm. So we've looked at the skin, we've looked at the mesoderm, so we've looked at the nature of the lump, and now we need to look at what is the impact on the neural tube, i.e., what's the neurological status. And for me, the neurological status in a lipoma is one of three. Either the child has no neurodeficit, or the child has been born with a fixed neurodeficit, which means maybe a partial foot drop on one side with which the child is born. Now the child may become 2, 3, 4 years of age, the same foot drop with which he's born. That's what I call a fixed deficit. And finally, of course, a progressive deficit. And we will have reason to come back to this because it depends on this, whether this child is going to still be running around or not. Okay, what investigations would you do for a lipoma? And the answer, of course, for for all tethered cords, we generally like to get a whole spine film because we like to know whether they have any other congenital skeletal abnormality in the spine. The MRI, of course, has always been the gold standard. If you look at the central picture, these are the things you look at on that MRI. Where is the conus? At what level does it terminate? And you can clearly see it's terminating here pretty low, almost at the sacrum. What's the connection with that lipoma? So in other words, is this dorsally located or is it inferiorly located or both? And we'll come back to that in a minute. And then, of course, we look at the axial cuts again to see the connection. Remember, there is mesoderm, which shouldn't be there between the skin or the cutaneous ectoderm and the neuroectoderm. I like the coronal image because it gives me an idea about the asymmetry of the conus. You may get a CT. We don't really do this very often in small children because of radiation reasons. And of course, very importantly, you need to image their brain. The MRI has led to us being able to distinguish anatomically different types of lipomas. And fundamentally, lipomas are of two types. Lipomas that arise from the phylum terminale, which are called lipomas of the phylum, and this applies to 15% of lipomas. And lipomas that actually arise from the conus, which we will call lipomas of the conus. So here's a lipoma from the phylum terminale. That's what they look like. If you want to operate on the phylum, a lipoma of the phylum, this is a completely different ballgame from operating on the lipoma of the conus. All you need is a pair of scissors, identify the fatty phylum and chop it off, an operation that most hospital security guards could possibly do. And that's what the thickened phylum looks like. And of course, we know this is a problem of incomplete retrogressive differentiation, which is what the caudal cell mass is subject to during the process which we call secondary neurulation, which is the process by which the caudal cell mass joins the bottom of the neural tube. The conus lipomas have further been divided, and there are a number of classifications, but this is possibly the simplest one. And this diagram is a diagram from the original article written by Dr. McClone. And of course, this is a dorsal lipoma, by which is meant that the lipoma is situated dorsally with reference to the conus. And Professor McClone's original diagram gives you a very clear idea. And this is what it looks like. There's the conus, there's the lipoma extending dorsally. Terminal lipomas are lipomas that start where the conus finishes. So in other words, that is the end of the conus. This is the lipoma. So where the conus ends, the lipoma begins. And as its name suggests, that's called a terminal lipoma. If you have a lipoma which is both dorsal and terminal, so it's both on the dorsal aspect and at the terminal aspect, then for want of a better word, Professor Chapman called these transitional lipomas. So there is a dorsal component and there is a caudal or terminal component. And finally, Professor Pang added this. This is figured from his original article, where you have this fatty tissue going ventral to the neural tissue. And Professor Pang called these chaotic lipomas. So we have lipomas of the phylum and lipomas of the conus. Lipomas of the conus can be dorsal, can be terminal, can be transitional, or can be chaotic. Very simple so far. The important thing is what determines your treatment strategy. Well, treatment strategy depends on the neurological status. If they have no neurodeficit, then the question is, why operate? Do we need to, as the leader of the first expedition to Mount Everest said when he was asked, why do you want to climb Mount Everest? And his answer was, because it is there. So do we need to operate on the lipoma because it is there on the MRI? And obviously this begs the question, why operate if the child has no neurodeficit? If the child has a fixed neurodeficit, then the question arises, will this intervention alter the neurodeficit? I told you about a child who's born with a foot drop, now 5 years old, same foot drop. Is this surgical intervention likely to impact his neurology? And the answer most definitely is no. And you have the third category, children who have progressive neurological deficit. There is no argument that if you have progressive neurological deficit in any neurological condition that is amenable to surgery, they need surgical intervention. Now, all the controversy started because of patients that were asymptomatic. And I call this the Paris versus Chicago argument. And here is the two representatives from these two cities. On your right, Professor Dackling Pang, on your left, Professor Michel Gérard. As I prepared to read out the menu to them in a dinner in Calcutta, where both were present together, and not arguing for a change, but having dinner. And what is the rationale of this Paris versus Chicago argument as far as asymptomatic lipomas were concerned? Now, this was the logic put through by the Paris group, and one that is absolutely correct. If you consider asymptomatic surgery, you must be sure it doesn't produce any neurodeficit, or it must prevent further development of the neurodeficit. So you must prove it will not provide any further deficit, and itself, it does not cause neurodeficit. But even more, you have to establish that waiting to intervene, which means the lipoma will increase in size, does not cause this lipoma to produce more tethering and more deficit. So you have to establish all three of these if you're going to defend prophylactic surgery for a lipoma in a kid without any deficit. Here's the results. The meta-analysis published in Child's Nervous System many years ago of 18 papers looked at the rate of neurological deterioration following surgery for asymptomatic lipoma. Surprisingly, the figure ranged from 4 to 16%, depending presumably who was doing the surgery, how, and in which part of the planet. As I said, you could do asymptomatic surgery if you proved that this surgery prevented further neurodeficit. But the question is, do we know the cause of neurological deterioration? Is it the tethering alone that causes neurological deterioration? Or is it an inherent deficiency in the formation of the neural tube itself? Remember, it doesn't close and the mesoderm comes and sits on it. And finally, this was the argument put forward from Paris. Looking at patients that had early surgery and patients that were managed conservatively, the Paris group showed there is no difference in the two groups. In other words, the natural history of the lipomas was such that whether you operated or you didn't operate on these asymptomatic lipomas, some years later, the same percentage would have the same neurological deficit. This is a slide which is very valuable to me. This is a slide from Professor Alain Pierrecan's original paper. And this, he was very kind to lend me. This is what he said. He said, this is very difficult surgery. It is limited surgery. In other words, you often can't untether that cord completely in these lipomas. He showed they had an incidence of pseudomeningocele of 20%, which is probably a little higher than most of us feel. And they had post-operative deficits, which was almost 4%. And I show you this photograph again from Professor Pierrecan's original slide, just to demonstrate that even that time in the late 70s and early 80s, they were using neuromonitoring. So these were not done without neuromonitoring. Well, this was the reason that the Paris group said, and even more, they showed that ultimately 100% of these lipomas get attached or tethered again if you look at them with MRIs. So what's the point of rushing in to these asymptomatic lipomas? This was the publication published in 2004. see 25% of patients who were asymptomatic deteriorated. 25% in a follow-up of almost 5 years. And they concluded from this that conservative treatment is a reasonable action for asymptomatic lipomas, because in the natural history, as they demonstrated after surgery, still, if you look at them for 5 years, about 20 to 25% will deteriorate anyway. Great arguments. Further, they showed that if an external lipomas grow at 20%, so should internal lipomas. The Vancouver group in Charles' nervous system disagreed with this in their publication in 2016. They disagreed with the deficit. They agreed that there was delayed deterioration. And they felt that this delayed deterioration is unrelated to surgery. But it was the seminal publication of Professor Pang who showed that in his own series, there was a great difference in neurodeficit in the ones that he did total removal of the lipoma versus partial removal. And this is from Professor Pang's publication. And that's what today we have learned to do. Total resection, he told us, has a much better outcome in the 90% than no surgery. And very importantly, he said that if you develop a deficit, then only 1/3 will improve with surgery. And very, very importantly in this publication, Professor Pang told us that partial resection has a worse outcome than no surgery. Gradually, of course, Paris and the Americans on the other side got together, apart from the fact that Professor Pang himself defected across the Atlantic. But both groups agreed that with dorsal and terminal lipomas, these are simple undertakings, you can take the whole lipoma out. For chaotic lipomas, clearly this was a very difficult undertaking, and most agreed that you don't rush in where angels fear to tread. For transitional lipomas, the controversy still persists. Do you operate on an asymptomatic transitional lipoma or not? And the answer, if I ask myself, this depends on 3 issues: experience of the neurosurgeon. It depends on whether you have available to you intraoperative neurophysiological monitoring, and to some extent on parental expectations. So let's go through very quickly the steps of the procedure. Here's a lump, that's the MRI. We find that in low lipomas, it is quite nice to give an incision which is curvilinear like so, because that keeps your skin margins well away from the inus. And this is our preferred incision, a nice U. A wide laminectomy. Remember that Professor Pang, this is again from his publication, told us that's how the lipoma is. So unless you do wide laminectomy, you're not going to be able to see over the edges of that lipoma. And then, of course, the wide laminectomy starts, and then once you've done the wide laminectomy, you have to expose the lamina cranial and caudal to the lipoma. And of course, often caudally, you may not have a lamina, but you expose the dura cranially and caudally. And this is an instrument which I love, and I'll come back to it a little later. It's a groove dissector. Here's the dura exposed cranial to the lipoma, and then it's exposed caudal to the lipoma. So I like that dura to be exposed cranially and caudally before embarking on resection of the lipoma. And then you work around the lipoma. Again, you see that groove dissector. This is actually an instrument which I picked up from pediatric surgeons doing cleft palate surgery. I love this instrument because it allows you to put your instrument in as you're untethering the lipoma from both sides. It allows you, you can see here, that's the cord, that's the lipoma. It allows you to put this instrument in and then use a number 15 blade to cut over the groove. And I think that's probably one of the safest way to untether. And as you work around the lipoma, on all sides, you also reduce the size of the lipoma. And as you can see, that's the conus, that's the lipoma now. We've got it, we've worked right around it. We've made it nice and small in size. And I use bipolar diathermy at times, and now you can see that's the pia on one side, this is the pia on the other, and this bit of lipoma that we're taking out is intramedullary portion of the lipoma. Now I have here a small submission and possibly a little difference with Professor Peng. I think the important thing is not to take the whole lipoma out, but the important thing is to make sure you take out sufficient lipoma so that you can get pia to pia neurulation. So if you have a little bit of lipoma going intramedullary to 3 or 4 segments above from where you are, you don't need to rush in to take that out, as long as you can get a complete pia to pia closure. And this is, as you can see, that's how small the lipoma has become now. That's a pia, that's on one side, that's the pia on the other. And we take the remaining bit of that lipoma out as well, so that eventually it's a situation where you can have a tube like this with a pia to pia suture, no lipoma visible, and you can have the whole pia closed. That's important, I think, much more important than complete resection of the lipoma. You have a drop or two of lipoma inside, but you've got that pia to pia closure. It is our humble contention, it makes no difference. And then finally, of course, we would get the filum terminale and chop it off as the final act of untethering. Now, if I have a few more seconds, I'll just quickly take you through another very quick video of the procedure.
You have another 3 minutes. You can please.
Yeah. So very quickly, are you seeing the screen?
Yes. The slides.
Okay. So I showed you the incision, so I'm not going to go into the details of this, but this is the exposure of the lipoma from all around.
Now we are not seeing the screen, sir.
You're not seeing the screen?
No.
Okay, wait. Let me just see what I can do about that. Okay, are you seeing it now?
Yes. Yes.
So, as I showed you, again, the important thing is, see, I neurulate, even if there's a little bit of fat there, it doesn't matter if this pia and that pia can be opposed. And that's the important bit, I think, in neurulation, that even if you have a little bit of fat inside there, trying to get into that intramedullary component and risking a neurodeficit, in my opinion, is not worthwhile if you can get a complete pia to pia closure in that way. And this is what the point I was trying to make. And of course, at the end, the interesting thing is, quite often with these dorsal lipomas, you can separate everything and you can get that dorsal lipoma to go back into the sac itself. So I think probably just show you a little bit of how this is the final step of cutting. Again, I'm going to show you, this is a different patient, but just to show you again very quickly how you can take that fat out. Just fast forwarding this so that you get the principle. You see that lipoma in the center doesn't matter if you can get these two pias opposed. And this is a point that I repeatedly say, if you can get that pia opposed, you see there is no fat now visible as you've closed that lipoma. Okay, so what are our complications? Obviously, the most dreaded complication is CSF leak as far as I'm concerned. And I'm still waiting for some bright person like Dr. Narain to tell us how you can do this surgery and not have CSF leak. 15% is my incidence, and I am unashamed to admit that. 6% of our children have had neurodeficit, but over the last 10 years, we have been doing monitoring, and the deficit has certainly come down. 5% retethering is based on a follow-up of only 15 years, because that's the data that we have. And when we go back and look at 25 years, maybe we will change that figure. So the follow-up you need to do is obviously neurological, urological, orthopedic, and of course look for clinical retethering, because of course we know radiological retethering has no value. Thank you very much for your attention, and I think I have 3 or 4 minutes, so if you want to ask anything, you can.
Thank you very much, sir. Extensive and comprehensive coverage of the entire topic of lipomas in such a short period. Amazing. Thank you very much, sir. We have some questions in the chat box. One is from Nilufar, who has asked, do you use CUSA for intradural lipoma removal?
Okay. I'll tell you the truth. I have tried using CUSA in the past, many years ago. I never use it today. Never. Absolutely never. Because ever since we started doing intraoperative neuromonitoring, we have seen how the potentials fall if you're doing MEPs when you use a CUSA. So the answer is today, I never use a CUSA. I have used it in the past, but I wouldn't recommend it.
Yes. Then can untethering without excision of lipoma be a rational treatment? By Dreamath.
I actually answered that question. If you do not excise the lipoma enough to get a pia-to-pia neurulation, then that fat that is going to be protruding out is going to cause retethering. This is why patients who have partial removal end up with neurological deficits. This was exactly the reason why the Paris group originally said, don't operate on them, because they did partial removal. So I think it's very important. As I said, I qualify my phrase total removal by saying total removal to get a pia-to-pia neurulation. I don't chase every single droplet of fat into that conus, as I have seen Professor Pang do, but he's an expert surgeon. I have to say, I feel a little inhibited to chase that last drop of fat deep into the conus, wanting to get an MRI which shows no white blob. But I'm quite happy to leave a little bit of fat if I can get a pia-to-pia neurulation.
That's nice. Professor Class is here. He has asked a question. Dear sir, that was just a second. He's asking about what kind of monitoring would you suggest?
So we do the routine, we do motor remote potentials, we do free running EMGs, but really the most important thing is to use a direct stimulation with a bipolar stimulator, and ideally one of those concentric types. I had no time to cover the monitoring because that's a whole lecture, but bipolar stimulation, because really often you find these little strands and you want to cut it. If you saw in that last video, before I was reducing that conus, I was cutting the last few strands, and you want to know, is this neural tissue worthwhile keeping or not? And you can stimulate it and check. And if it's not, you can chop it off to get a complete untethering. So we would do all of that. I haven't used the dorsal nerve of penis that much. We're not that experienced. I know DCR is something Professor Pang recommends. We've tried it a few times. I have to confess, we have not yet developed the expertise of monitoring DCR.
Okay. Further interesting questions are coming in the chat box. For want of time, maybe I'll ask one last question from Pascal Gallo. Dear Sandeep, do you recommend some restrictions on some specific physical activities for asymptomatic patients you decide just to follow?
No, I don't. I don't think there is any point in restricting physical activities. We restrict physical activities on our patients at a drop of a hat. I don't think lipoma should be added. No, I would not.
Yeah, this is for everybody's interest. The one last question. There is no risk of regrowth of the lipoma when it's embedded in the spinal cord after pial closure, from Abdullah Zaidin.
Well, the answer to this honestly is, we have had patients, what we generally do with these lipomas is, I didn't have time. We do an MRI 24 hours after surgery because I like a demonstration of how much untethering I've done immediately. Some children who will need anesthesia, believe it or not, we get an MRI done from the operating theater. So when I finish, they're not woken up. They have an MRI and then they're woken up because they need another anesthetic if you're going to do an MRI after 24 hours. That's not appropriate. So we get an MRI every time. We get an MRI after 1 year, and then we do, just for our study, we're doing an MRI every 5, 10, 15, and 20 years. So far with the data I told you we have for 15 years, we have one child out of a few hundred that has, the residual lipoma has grown. So I don't think it's very significant. I mean, the amount of lipoma that you leave behind is minuscule, remember. That little bit that you can't get out, which is deep in the corners, and you're just closing the pie over it. It's not that you're leaving a massive lipoma inside.
Thank you very much, sir. That was wonderful discussion. Few more questions in the chat box. I request you to please answer in the chat box, sir.
Okay.
Thank you very much, sir. Wonderful.
Thank you.
Naren, Naren, you're not audible.
Thank you very much, Komal. It's my distinct pleasure and privilege and indeed honor to introduce Professor Ashok Mahapatra. He's a doyen of pediatric neurosurgery internationally, but also of India, and he's an inspiration to many. So he's going to talk to us about encephaloceles. It will be a real treat, and I'm really looking forward to it. So if Professor Mahapatra could upload his presentation, share the presentation, please. And Prof. Mahapatra, it's your choice. Are you happy for the presentation to go live stream on the YouTube, or you rather?
Right, no problem, no problem.
Fantastic.
Okay, go ahead.
Thank you.
Thank you, sir.
Can you start now? Should you start?
I think it's once you have shared it.
Yes, we can go ahead.
You can start. You want to maximize the slide, please? Thanks.
Sure, sir.
Thank you.
Good afternoon to everybody. My greetings from India. Thanks, Naren, and all Dr. Komal Prasad and Dr. Sandeep and friends across the world. I can only first say my condolences to all our friends, doctors, those who have died of corona, and my sympathy for the family of 400,000 people, those who succumbed to corona. And today we have 6 million people have suffered. Currently, we have had about 120% of corona in our hospital, as we are managing a corona hospital of 500 beds. My greeting and my topic is encephalocele. As we all know that encephalocele, like any hernia, is a herniation of brain through a orifice or a defect. And it is like it has content and a sac and a defect. So if you look at any type of herniation, we have to manage the hernia considering their effect, their content, and the amount of tissue has to be repaired because of defect. So if we look at the embryology, Dr. Sandeep was talking, I'm not going to talk about embryology bit, but what is most important for us, everybody to know, amongst all congenital malformation, 50% central nervous system malformation, and incidence is 1 per 1,000 live birth. And 50% people, embryo, which is they're born with either stillbirth or abortion, they have their malformation or congenital malformation. So we know that neural tubes start between 15 and 25 days, and neuropores, anterior neuropore and posterior neuropore and neural tube close very fast within 10 days between 15th day of gestation and 25 days of gestation. And there are several steps within that 10 days, and that is a very fast process which we are not going to detail. So there are different stages. If you believe in the theory of neural tube closure, there is one theory called jeep theory, where it believes that it starts from one place and proceeds in one direction like a jeep and close at the other end. But if you look at the Van Halpen theory, it doesn't believe in jeep theory, and it's a multi-segment closure, so that it's closed in the cervical, dorsal, lumbar and sacral separately, and junctional area are more prone for herniation, because that is the area where there will be defect in the bone and the dura. So the question is that we have to believe whatever may be the hypothesis. So there are a large number of stages involved in the closure of neural tube. If we believe that neural tube is primarily closed and then ruptured, then the question comes that there is intraneural tube pressure which causes secondary rupturing of neural tube. But these hypotheses are still in hypothesis. We do not have evidence to prove one or the other. Now let us talk about different stages. There are a large number of stages. It is the anterior neuropore defect, which happens in the 11th stage of just the embryogenesis, that produce the herniation of brain. That is around 25 days of gestation. So if we are talking about anterior neuropore defect, That's we are talking about 25 days of gestation. So you have all the anterior part and caudal part and whole lot of the entire neural tube. So we are not going to talk details about that because that will fool embryology. The major steps are spinal cord development problem, then the craniovertebral problem, and also the brain development problem. So it can be gastrulation problem, neurulation problem, or secondary neurulation problem, or caudal mass regression problem. This can produce whole lot of CNS malformation. Now neural tube defect or neurointestinal defect or caudal tube all will give various type of malformation of central nervous system that we are not going to in detail. So you can have a variety of, a person can have a variety, could be total absence of the brain to encephalocele, hydrocephalus, and schizencephaly. These are all neural tube defect in the anterior neuropore, which happens on the 25 days of gestation. Now we have got encephalocele. That is the neural tube defect at the anterior neuropore. This can be classified as anterior and posterior. This is an arbitrary line which pass through the coronal suture. Anything in front of the coronal suture is anterior, and anything behind the coronal suture is posterior encephalocele. We can have anterior encephalocele come to the ethmoid, nasofrontal or nasoorbital. Posterior could be vertex, which is parietal bone, could be basal from the basifrontemporal, or could be basiparietal, or it could be transtemporal to the tegmen tympani. It can also arise from the other defects, which is suboccipital. So posterior can be classified as occipital, which through the occipital bone may be midline or paramedian. Torcular, when it's torcular, there could be confluence of sinuses or one of the transverse sinus there present. It could be the midline or lateral when it is vertex encephalocele. Basal encephalocele could be anterior frontal basal cell, temporal basal cell, transcaval basal cell, and it can have the transtympanic, where the encephalocele can come to middle ear. In fact, I had one patient who had CS otorrhea and ultimately proved it has herniated to the tegmen tympani. These are the bone defect where you can see the bone defect in the midline, and the eyes are differently slant in case of anterior encephalocele. Now, if you go to a whole lot of encephalocele, about 10% of encephalocele in India will be anterior, and about 70–90% will be posterior. That means every one we operate for the anterior encephalocele, 9 of them will have posterior. In about 40 years time, we have collected maybe more than 600 encephalocele. But today I'm not talking about that. My experience at AIMS New Delhi between 1970 to 2012 is about 400 encephalocele. If you talk about naso-infant, it arises from the nasal bone and nasal cartilage. Here it is ethmoid bone. It comes through one ethmoid to the nose. When you talk about naso-ethmoid, it could be unilateral, bilateral. Here it produces classical hypertelorism because there's a midline swelling in the ethmoid coming to the nose, nasal cavity. It pushes the eyeball, producing hypertelorism. So this is the classical anterior encephalocele, which is naso-ethmoid group. Now you can have nasopharyngeal, transorbital, when the sphenoid wing is absent. This happens in neurofibromatosis when the sphenoid wing is absent. I have a whole lot of 10 to 11 cases. Transcellular, when there is a defect in the cellular bone, it can come to the sphenoid, planum sphenoid, and maybe to a tuberculum celli. It can come to the floor of the cella, and about 30 cases reported in the world literature, and luckily or unluckily we have 5 of them, and out of that 1 person succumbed after the meningitis post-operatively. We have interfrontal between 2 frontal bones. So if you see that interfrontal between 2 frontal bone, nasofrontal, transsphenoidal, then here is the encephalocele sitting in the frontal bone. It is in the frontal bone, not between frontal nasal bone, not between nasal bone and ethmoid bone. And all these are very important to understand. Here is a young boy which at birth is a ruptured meningocele at the frontal area. So these are the things, whole variety of anterior frontal or middle frontal or transethmoidal or transphenoidal. Mostly they present with a swelling here. The swelling could be above the nasion, at the nasion, or below the nasion, depending on frontonasal, frontoethmoid, or frontoorbital. If it is in the inner canthus, it is called nasolacrimal because it comes through the defect in the lacrimal bone. So it will produce only the pushing of the eyeball in one side. Maybe it is unilateral, there is a hypotelogism one side, other eye is normal. So there could be swelling at the root of the nose, at the bridge of the nose, or in the forehead, depending on what type of encephalopathy. There will be proptosis, depending on how much the herniation has pushed the eyeball outside. What is more important is that if it is not seen and come to the nose, it is confused with nasal glioma, or it is confused with nasal polyp, and usually ENT surgeon will biopsy and they will have CSF leak. There could be spontaneous rupture of the meningocele and they may produce recurrent meningitis. So one of the presentation is recurrent meningitis. So in our cases, meningitis, cleft palate, neurofibromatosis, leaking meningocele, hydrocephalus, this is not as common as posterior encephalocele. If you take 100 cases of posterior encephalocele, 90% will have hydrocephalus, and that has to be treated with its own merit. When you talk about anterior encephalocele, about 15% will hydrocephalus, and you may not have to put a diversion in all cases because after the repair, many of them will settle down. So this is very important point to understand that hydrocephalus may not require a diversion here. So if we look at the, why do we investigate? We investigate to see what is the defect, how much the intracranial anomalies, and how to manage the defect hypotelorism, whether you have to have an associated hydrocephalus or there is also cortical dysplasia that can produce in the future, there is intractable epilepsy. So all these are very important aspects to be analyzed. Here is a case of transethmoidal encephalocele coming to the nose and there was no swelling in outside the frontal, seen outside. So why do you operate? We investigate them. Nowadays, we do not do CT scan, we do only MRI. In early 70s, 80s, maybe late 80s, we are doing CT. No MRI was available, but we are doing MRI now. Our aim of the surgery is to correct the deformity and repair the encephalocele. If there is a hydrocephalus which is not regressed, we may have to put a diversion, mostly a low pressure ventricular peritoneal shunt. So these are the things where you have to plan, because you have to do a bicoronal flap. You have to see what is the asymmetry of the face. This is called facial cone. If you have the craniofacial surgeon or maxillofacial surgeon, they will talk about maxillary abnormality and facial abnormality, and your area of interest here may be maxilla, nasal bone, frontal bone, and sometimes nasal cavity. So this is very important to understand. This is a craniofacial or maxillofacial or multidisciplinary approach, maybe plastic surgeon. So aim of the surgery to repair. So that is what I have shown. You have to correct the deformity at the nose. So extra bone has to be removed, and then the orbit has to be mobilized medially, and there the interorbital distance, inner canthal distance can be reduced 2.5 centimeter, which is normal. So that is the steps one has to follow. So this where after the craniotomy, you can see this is nasal cavity going here. This is the cribriform plate where the hernia is going down, and that has to be excised with the glass brain. And initially I used to do the intradural repair. Nowadays I don't do intradural repair, because if you can open the dura here and excise the glass brain, which is inside the nose, then you can repair the dura here either directly closure by suturing or by putting the graft and glue. Both are there. So extra bones are removed. If you have a hypotelogy more than 2 centimeter, you remove the bone. Extra bones are cut from the midline and put the graft in the supraorbital margin. This is what is called modified Tessier's operation. We all know that Professor Tessier described this operation 1966. We have been doing this operation from 1971, and we have operated all the patients by doing one stage craniofacial correction with encephalocele correction and hypotelogy correction. So these are the patient steps of the operation. At the end of the operation, these are like that, and hypotelogy get corrected. These are the whole gamuts of the patient. Let's see, they come different. Mentally retarded, normal. This is one of the patient where lacrimal bone was defect and there is hypotelogy. So we had to excise the extra skin in the inner canthus. So that is the whole gamut. Here is a child, a newborn child, where the encephalocele is coming through the forehead here, large one. So we have to excise. This newborn baby has to have craniofacial surgery at 2 days of birth. This is what happened. This was coming through the nose, and then we have to operate. And these are the transnasal, transsphenoid encephalocele coming to the nose. And these are the very, very difficult situation. There are two types of operation, either transcranial going to the planum sphenoid, or transnasal by either through the transpalatal or through endoscopic approach. There are only 30 cases in the world literature. These are the bone cords diagrammatically represented, and I do not want to go to details of that. Here is another case, of interesting case, where the encephalocele was coming to the anterior fontanelle. This is anterior fontanelle encephalocele of a 3-month-old child. I have 3 of them, and this child was operated, but he was mentally retarded and have recurrent seizure. So seizure and mental retardation is quite common, about 30% cases of these people. So this is a case, craniofacial surgery newborn. One can ask, what is the right age of surgery? Right age of surgery of a anterior encephalocele or transethmoidal encephalocele is 6 to 8 months, because that is the time when the child is about 6 kg and he can stand the surgery. But sometimes we do craniofacial surgery in young child because they're leaking or they have problem in respiration, eyes are closed. This child has to be operated at about 3 to 4 days after birth. So it is very important to understand. Or there is a leaking CSF, breathing difficulties in a child at birth, or large swelling which is not enabling the child to see. So these are the acute stage when a child requires craniofacial surgery at birth. So these are the very important thing. Transcellular, there are only 30 cases reported. We had 4 cases, and they are very, very difficult problem. And this is a child where the one orbital eyeball was absent, the cleft palate, cleft lip, endocrinal problem, respiratory problem, and we had to operate a 2-month-old child who came with respiratory problem with transcellular, transsphenoid encephalocele. They are very rare, but that needs to be mentioned because one may have to be confronted with that. So we are not going to go to details of the transcellular, cranial approach, palatal approach. Result are good if it's done properly. These are another transsphenoid encephalocele. Now complication could be wound infection, CSF rhinorrhea, because you are operating the anterior skull base, and quite often maybe 4 to 5% cases meningitis. So let us see the occipital encephalocele. We have a large number of occipital encephalocele, but because it is done by the other people, they don't come to us. Or because anterior encephalocele is specifically done at AIMS, we catch them early and operate. But posterior encephalocele can go to other places in Delhi, they get operated. So when you analyze in a 5 years data, 6 year data, this is the breakup. So these are the very large encephalocele. I had 30 giant encephalocele. These encephalocele, we defined giant encephalocele when the perimeter of the encephalocele larger than the circumference of the head. So large number of people can have a smaller head, and this could contain only CSF, maybe CSF and the brain, or maybe only brain and nothing else. So one has to be very careful this, and sometimes there may be brain with a torcula or the part of the sinus here. So we have to do MRI with MR venography. Very large, the largest case, the single case I have seen, whose encephalocele was weighing 8 kg and baby was weighing 3 kg. This baby was, one of the baby was 11 kg, but the encephalocele was weighing 8 kg. So this was one of the largest encephalocele I have seen. So their problem is that they have secondary craniostenosis because there is a herniation in the large amount of CS and brain. They will have craniostenosis. So at the end of the surgery, you have to do a bicoronal craniectomy so that post-operatively the patient do not have raised intestinal pressure. So I will show you. This is one of the child who has 3 liters of fluid, but I have only kept 2 bottles because I aspirate. So the manipulation of the encephalocele becomes easier because it's a huge encephalocele. Going around and exercising very difficult. So what I do, I aspirate as much as possible so that the manipulation and rotating the skin and planning the skin flap become possible. So the aim is to again excise the content and then repair the dura and do the bone reconstruction. I always go for the reconstruction of occipital bone and do a craniectomy at the bicoronal suture. Large number of, see that here is the, and here I have done a large giant encephalocele, operate here and do bilateral coronal craniectomy, suturectomy, so that you are not providing, because the suture is fused, you have to give space for the brain. So again here, it's a chance of CSF leak, meningitis, because they are very small children, they have very little resistance. So CSF leak and the meningitis is a true problem. Why do they die? They die sometime because of hypothermia, prolonged surgery, and meningitis. So I had 5 deaths in about 200 cases. 1 patient died of pneumonia, 2 died of hypothermia following that, and 1 with meningitis. In conclusion, meningoceles and meningoencephalocele are not very common. Over a period of 40 years, we have operated about 600 cases. So average we see 15 to 20 cases per year. But what is more interesting, we have collected a series of more than 150 cases for anterior encephalocele. Anterior encephalocele occurs 1 in 250,000 in Europe and America. However, in Southeast Asia, anterior encephalocele is seen in 1 in 5,000 bar. So unexplainably, in Southeast Asia, anterior encephalocele is more common than the rest of the world. So we have to have sometimes 10% giant encephalocele, when the encephalocele has to be managed differently. And the occipital encephalocele accounts for about 80 to 90% and about 10 to 20% anterior, because we have a selection by bias, because we have got referred cases to our center for anterior encephalocele. MRI is nowadays the choice, because before MRI era in 70s and 80s, we used to CT scan. However, CT scan sometime may be required to see the bone defect if the child is sometime more than 3 years old. We get about 10% children at AIMS Delhi about more than 2 or 3 years old, and doing a CT may not have that much of implication. So our aim and objective is to manage these children in a planned manner, and if required in emergency, in an emergency situation like a rupture frontoesophageal meningocele or a large meningocele in the forehead, pressing on the nose or sitting on the mouth, which produce respiratory obstruction, requires or merits an emergency surgery for saving life. So saving life is not by and large is required in case of encephalocele. What is necessary is a plan properly. In anterior encephalocele, we have to include craniofacial surgeon, plastic surgeon, sometime maxillofacial surgeon, because they may be giving you a lot more cosmetic correction than a neurosurgical perspective. So it is teamwork. Despite of our experience, we can still have 4 to 5% mortality because of hypothermia, post-operative meningitis, or even pneumonia. So one has to consider these patients are very delicate and prolonged surgery. When you started in 1970, mid-70s, it used to take 12 to 13 hours. Today, we can finish this surgery within a span of 3 to 4 hours. So with skill and experience, the surgical time has gone down. Even then, the mortality and morbidity can never be underestimated. So it requires a teamwork, it requires proper planning, it requires blood transfusion and proper anesthesia. If we can have all this, then we can have a very good results. Thank you very much.
Thank you very much, Professor Mahapatra. That was a fantastic talk. I think everyone is absolutely impressed. It's an immense experience and certainly has been very useful for me. We have got time. I have got 3 questions for you from the audience. So the first one I'm going to ask is from Dr. Noor ul Huda. It's coming from Punjab in Pakistan. Her question is, in the brain that's in the encephalocele sac, is there a way of knowing whether this is functional brain or not functional brain?
Usually when we send this excised brain, it is glass brain. We do not do the intraoperative corticography in small children because we are talking most of the children, 80 to 90% children are below 1 year of age or 1.5 years. So we do not go for neuro monitoring. But whatever part of the brain we excise from the nose, they are glios non-functional brain. We do not try to remove normal looking brain. So we have only histology of the excised brain from the nose. So those are not normal functioning brain.
Thank you. I'll probably come to that question again, but I will just move to Dr. Mikhailo Lovka. He's from Ukraine. 2 interesting questions. One is when it's posterior encephaloceles, when there are large blood vessels, do you have any tips or tricks on how to preserve them, and should they be preserved? And if so, any advice?
It's very good question. Mostly there's a vein which comes in the midline. There is no significant artery in the posterior encephalocele. So that if it is a torcular or subtorcular, we may sometimes encounter the confluence sinuses and transverse sinus. That case, we have to have a MR venography. If MR venography shows that, then we have to excise the sac, not including the sinus. So what happens? If you have the sinus in the sac, then preserve that part of the sinus, and extra redundant sac you can leave, but you cannot fiddle with the venous sinuses. As much as arterial concern, there is no major artery here. So I'm not bothered for major artery. I'm only bothered for the confluence sinus and transverse sinus.
Thank you, Professor Mahapatra. One more question, and for the want of time, there are many more questions, and they're very good questions for you on the chat box. One is that if the encephalocele is communicating with the 4th ventricle, what's your advice?
I have not seen any meningocele has been or encephalocele communicating 4th ventricle, but 4th ventricle can be herniating with the part of the cerebellum. In that case, we would not like to excise the cerebellum. There are case reports where the people have given a cranial graft to accommodate the herniated brain. But I don't go to the 4th ventricle because 4th ventricle can herniate, but we can gently push the cerebellum with the 4th ventricle so that you do not disturb the 4th ventricular dimension and circulation of CSF, because that will going to produce, if you open that, then you have problems of CSF leak and other problems, air going to the ventricle, pneumocephalus. So by and large, if there is a cerebellum herniating with the 4th ventricle, excise the glass cerebellum and keep enough cerebellum over the 4th ventricle and gently push them, then repair the dura. That will be ideal. I would not fiddle around the 4th ventricle thinking it is okay, open the 4th ventricle, but the complication rate will increase.
Just a follow-up question. Thank you, Prof. Just a last follow-up question. In terms of knowing whether it's functional brain or gliotic brain or the one in between, how easy or difficult to say it's gliotic, it's functional, and the gray area in between, just through?
It is practically impossible. Our aim in occipital encephalocele to preserve all brain, because there is no question of sacrificing unless there is a huge amount of brain coming and there is no way of closing the encephalocele. But if it is frontal encephalocele, large amount of brain will be inside the nasal cavity or ethmoid cavity. That is very sure that the brain, when herniate out to the nose or the ethmoid sinus, it's glass, because the look is that they look fibrous. They look like fibrous tissue, and we caught with seizure. And when you send for the biopsy this tissue, they come as severely glass brain. So when you talk about brain inside the nose or nasal cavity or ethmoid, they are very fibrous. That doesn't happen in encephalocele posterior, because that is full in the sac, and it is very soft brain, that not glass. So I am sure the posterior encephalocele brain are functional brain. We will always preserve them. But in anterior encephalocele, they are glass brain, and that biopsy shows gliosis, severe gliosis. So that is not a problem.
Thank you very much, Professor Mahapatra. It really.
Thank you very much. Thank you. I will answer those questions on the chat. I will answer those questions.
Thank you. Thank you, sir.
Thank you. It is my pleasure. It's a really pleasure to see all of you. Thank you.
Thank you. And the next speaker is Professor Uli Thomal. First of all, going to get Professor Thomal to share his presentation. Then I will introduce him. Uli, would you please share your presentation?
You see the screen?
Yes, excellent. If you just maximize it, then we are
After the question.
Okay.
So it's a real pleasure and honor to introduce Professor Thomal. It's even more pleasure. It's this course is the course of the neurosurgery research.
This question. The respiratory dysfunction is very high and need replacement theory.
This International Neurosurgery webinar course is the course of the Neurosurgery listserv, and this course we made it webinar because of the COVID. Otherwise, Dr. Komal Prasad and Dr. Timapa Hegde were going to organize it, a fabulous course in Mysore that we had to postpone because of the COVID. But that was the 5th course. But the first course, the inaugural course, was held in Charité Hospital in Berlin, organized by Dr. Thomal. It was absolutely well attended, and not only we had the same course that we are having in the webinar in Berlin, in the historic city center at the prestigious hospital, but also Dr. Thomal organized social events for every night for the faculty and the residents, and they could actually meet each other, and it was a fantastic event that probably gave us the step for the subsequent meetings. And not only that, he did it in an amazingly small budget and also had 4,000 euros still to spare. So apart from the fact that he's a fantastic surgeon, but fantastic organizer, but we have to thank Dr. Thomal for today as well. Dr. Thomal, it's yours.
Thank you very much, Naren. Yeah, that was great fun when we had the course in Berlin. Good morning to everybody. Thank you, Naren, and thank you to the Birmingham and Bangalore group for organizing this already very successful course on this webinar basis. I think we had a fantastic day yesterday, and you had already a couple of talks which are also addressing the topic of hydrocephalus. My topic will be complex hydrocephalus, which I will talk about now. The general idea, thinking about the pathophysiology, is taking this very well-known diagram from Harold Rickade, where he make you understand that the hydrocephalus dynamics are caused by arterial inflow, CSF dynamics, and venous outflow. And if we look at different types of diagnosis, for example, aqueductal stenosis, we can spot one point where the problem of hydrocephalus occurs. It's the Sylvian aqueduct. If we look at this plexus papilloma, we already have 2 points because we have overwhelming CSF production, as well as due to the midline shift, we have also occlusion of the foramina Monroe and as well as the Sylvian aqueduct. If we look at post-hemorrhagic hydrocephalus, we might have resorption problems, which is then at the surface of the brain parenchyma as well as in the ependema. But you could also have an aqueductal stenosis in those patients. So you have different spots, which is even more complicated in spina bifida, where we know due to the Chiari malformation, you might have outflow problem of the venous blood. You might have an occlusion of the fourth ventricle, and you might also have problems with the minor CSF pathways within the brain parenchyma itself. And last but not least, subarachnomegaly, or in older age, idiopathic intracranial hypertension is caused by a venous outflow problem. So all this, having all this in mind, we can go to Oi's classification, which is called the multicategorical hydrocephalus classification. And he puts those different factors together, looking at patients, CSF dynamics, treatment options, as well as categories and subtypes. And he ends up describing 72.5 million different types of hydrocephalus. So in general, when we talk about complex hydrocephalus, we have to understand hydrocephalus is, first of all, a complex disease itself. For a neurosurgeon, this classification from Oi is maybe too complicated, but we are focusing more on the techniques we have available. And these are intermittent hydrocephalus treatment options with external ventricular drains or reservoirs, and permanent hydrocephalus treatment options with endoscopy or shunt, or we might combine the endoscopy with shunt together. But even this, looking at different treatment options, I try to make a flow chart, what we are dealing with in different kind of hydrocephalus patients. And first of all, we always have to answer, is there a communication between the internal and external CSF spaces? And if there's no communication, then we look if the age is low, if there's a post-infectious component of a hemorrhageous component, or other membranes accessible for endoscopy. And these are the basis for deciding putting a shunt, or doing most of those cases, try to do endoscopy and try to avoid the shunt. If there is a communication, then the shunt is more prone to be put. However, we have to look if there's still some isolated compartment in the ventricular cavities. So there's a combination of resorption problem as well as communication problem within the ventricular system. And then we have to combine endoscopy with shunting. It becomes a little bit different if we have if we are dealing with intraventricular tumors. Of course, the first step would always be to take the tumor out. But if this is not possible, we have to choose for endoscopy to make a biopsy. Sometimes we try to do endoscopy, a biopsy, and doing ETV and avoid a shunt. But sometimes we have to do endoscopy and put a shunt in one patient. And last but not least, we have the endoscopic lavage, which came up in the past years and becoming more and more popular in order to avoid the overload of intraventricular intra-CSF protein and debris in order to avoid long-term complications. So I would like to go through this, and I will start with the non-communication part using endoscopy as first choice. And of course, we know that pure endoscopic for hydrocephalus mostly done in non-communicating hydrocephalus, as it is done in ETV. I will not talk about ETV in general because Professor Constantini have done so yesterday, but I just want to point out how important it is to have the right trajectory in order to have the direct view through the foramen of Monro, if you enter the lateral ventricle, directly on the floor of the third ventricle, in order to have enough space to work all the way down in the prepontine cistern and not being able to damage it. In our group in 2009, as well as in the Vienna group, they nicely did the investigation, how important it is to look at individual entry points. Here you can see that the direct trajectory through the foramen of Monro to the floor of the third ventricle is a very diverse entry point for optimally reaching these kind of targets through the anatomical landmark. And this can be directly planned by each patient. If you look as a target, your flow of the third ventricle, go through the foramen of Monro, and this line can be directly elongated to the surface of the skin or the calvarium, and this directly translates into your entry point, which needs to be calculated patient by patient. The other thing is that you, with your endoscope, you need to go into the ventricles. And if you do this with your optics, this is what you see until you reach the ventricle itself. So you have this blind pathway where you are not able to orient. And this is always gets you some relief if you're finally entering the ventricle. And for this, you might have either perfect planning or you need some technical help. It's always the question how to define your entry point, especially if you use a rigid endoscope, which we do, I think, the most in our community. And you have to plan the entry points individually according to the challenges you face per patient. And this means accurate planning and guidance of the target, respected landmarks, which you have to enter through, and then you end up having a trajectory and your entry point. In order to perform your neuroendoscopy, these technical aims you can get is either ultrasound. Ultrasound is very good if the fontanelle is opened, or you have the craniectomy, which is still there. So you are able to follow the path of your endoscope directly into the ventricle. However, in most of the cases, the fontanelle is not open anymore. And then you can use anatomical coordinates. You do a very nice planning, as I showed you before, which is very efficient, but maybe not always precise, especially if the ventricles are smaller. Navigation is a tool which you combine with neuroendoscopy quite often. It's precise, however, it's cumbersome. And if we only have to enter from the frontal area, we use a ventricular guide in order to be as precise and as efficient as possible in order to target the ventricles. And I will go through this as well. In basics, it's like this: training neuroendoscopy is the basis of all. But if you combine this with a good planning, with a good intraoperative view and navigation, then you have the key in order to perform more and more cases and make it less complicated. I would shortly stress the guide for the ventricle, because I think it's quite helpful in many cases to overcome the issue with the navigation, cumbersome, time-consuming. The guide has been investigated by our group, and this is, of course, my disclosure, which we have developed this guide together with a Mietke company here in close to Berlin in Potsdam. And we have investigated in a multi-center trial, prospectively investigating just for ventricular catheters, and showing that the malpositioning rate, which you can see here in red, could be dramatically reduced. And this amount of 10% still in the guided group have been catheter which have been either too long or too short. But also very important, with the guiding tool, we are able to access the ventricle in 100% of all cases by the first try, which was not able to be done in a freehand group. So I think it's very easy to perform. I just shortly introduce the technique. If you use a rectangular trajectory in the coronal plane towards the calvarium, then you normally enter too medially in order to reach the ventricle. You need to angulate your trajectory far more laterally towards the ventricle. That means more medially on the surface of the calvarium. And this angulation can be calculated. And we calculate it by the use of an iPhone application, by just integrating the coronal image of an MRI. And then we can use the guide in order to adjust this angulation, and then either use a ventricular catheter or an endoscope in order to target the ventricle accordingly. Yesterday, Professor Constantini already mentioned that this angulation is very important in order to target the ventricle accordingly. Here you have, for endoscopy, you can still hear me, yes. You have the view here with a shunt scope above and with the normal optics of a minor endoscope. And in both cases, you go through the brain parenchyma, just through the guide, and then the ventricles can be reached easily and very precise. This is another example of a suprasellar arachnoid cyst, which you can see here. The image was taken, put into the iPhone. Then we have a very clear deviation of the angulation from the rectangular plane, calculated to I have to see 12.5 degrees. And then we use this in the patient itself, use the endoscope in order to target now the ventricle. We have slight enlarged ventricles, so there's a hydrocephalus in this case due to the occlusion of the foramen of Monro. But the ventricles are not too large enough, and this is the typical case where you need some guidance, in my opinion, in order to safely reach the ventricle, as you can see here, and then you can further perform the fenestration of first the upper membrane and then the lower membrane, as you can see here, in order to open up the cysts cranially and caudally, and then have a free flow of CSF and solve the problem. For ETV alone, yesterday the Kulkarni score was already mentioned, and most important in the Kulkarni success score is the age, as you can see, which was nicely investigated by the IHS trial, where we can see that actually shunt in patients under the age of 2 years have less amount of revision than ETV. However, if you distinguish between lower than 6 months and older than 6 months, you can see that the difference between shunt and ETV is mainly in the very young infants younger than 6 months. So this is the threshold we are taking in order to decide in an aqueductal stenosis, for example, to use a shunt right away, or to use ETV only if the patients are older than 6 months. And all the younger ones we have to keep in mind for a later shunt revision, that we still can reverse the shunt to an ETV on long run. Complex hydrocephalus means not always a complex situation, which is the diagnosis itself, but it can be performed by the doctor as well. Here we have a clear aqueductal stenosis in an encephalitis, post-encephalitis hydrocephalus, and we did the ETV. The ETV was done without any problem. However, after surgery, we had a big problem of huge bilateral hygroma. And this was actually the fact, beside the fact that we did some gel form inside our corticotomy. But what happened in this case was actually that the subdural space was opened at the lower level below the floor of the third ventricle. And then actually this bilateral hygroma occurred, and the child was worse than before surgery. This reminded me on this Simpson kind of brain formation. We had to put a subdural shunt afterwards and drain the subdural cavities first, and later on, if the subdural space was completely empty of CSF, we had to transfer this shunt into a ventricular peritoneal shunt. So complex situations can be caused by ourselves, by problems we perform. This is another situation which is, I think, complex, because you can do an ETV here, aqueductal stenosis, but the floor of the third ventricle is not like it used to be. It is full of tumor in this neurofibromatosis patient. And in those kind of patients, we actually we are doing an ETV, but we stent the ETV. So we put a catheter. We use a ventricular catheter, which is guided by the endoscope, and then put, sometimes with navigation aids, into the third floor of the third ventricle. And this catheter will remain in place. You can see it here. You can see the tip all the way down, lower to this floor of the third ventricle, and here you can see how it's fixed with the reservoir, having perforation holes in the lateral ventricle, having perforation holes in the prepontine cistern, and then you have a sustainable communication between inside and outside CSF spaces as a replacement of an ETV. This has been published by our group in 2015, and we could reach a quite successful treatment in most of the patients, reaching the diminishing size of the ventricles. The only patients which were not suitable in this group were actually, again, the very young ones, which were then developing membranes around the catheter tip. So we tried it in very young ones, but it was not possible. Another complex situations are this so-called hydrocephalus of just one ventricle. You can see here that the unilateral ventricle is enlarged, the contralateral is completely small, and we have here the foramen of Monro, which is occluded by the membrane. We are using here a navigation system with augmented reality in order to see where we find our targets, and here the foramen of Monro can be opened. As you can see here, we just proceed the video a little bit, and then look into the third ventricle, which looks also very nice. And then as a second step, we also do a septostomy in the posterior portion. And I think this is very important to do those kind of procedures with a navigation tool in order to see where to perform your fenestration. Otherwise, you will not find the correct target in order to find the membrane to the contralateral side, which can be appreciated now here in the part of the video. In the postoperative image, you can see the opening of the foramen of Monro. However, we are not relying on this alone, and we're doing this septostomy in the posterior portion as well, which you can see here and here. Another complex situation might be if you look at this huge arachnoid cyst in the posterior fossa, how to deal with those, put a shunt, do a fenestration. Doing posterior fossa fenestration is not as easy. So I think navigation is also important. I think this video is not working. I'm very sorry about this. But I think it's important to find the right entry point, not to target, for example, the transverse sinuses, and also have good trajectories in order to reach the prepontine cistern, as well as maybe the membranes towards the fourth ventricle, and these can be opened accordingly, and then having good communication of the cyst, and then also having resolved the hydrocephalus by itself. In those groups, shunting is also of importance, and we have to avoid complex hydrocephalus by avoiding our complications we caused by shunting. And this is infection, using protocols, and sometimes antibiotic impregnated catheters. For obstruction, which is still a problem, but lavage might reduce the protein levels in the ventricles and thereby reduce the amount of debris, which might then later on occlude the valves. Navigated endoscopy in order to target multicystic hydrocephalus, place the catheters right by navigation or this guide, which I've shown you, and then the right drainage in order to avoid over drainage, which is one of the most important things in pediatric hydrocephalus treatment, as it was mentioned by Dr. Eula yesterday very nicely. So in the next step, I would like to go to the non-communication part, using endoscopy and shunt together in complex cases. And this is one example where we have a very high overdrainage with split ventricles in the supratentorial compartment, and in the infratentorial compartment, we have an isolated fourth ventricle. The first step we did is to increase the resistance of the valve, wait until the ventricles are enlarging, and then deciding for a supratentorial frontal approach, transventricular, in order to do a stented aqueductoplasty from here through the third ventricle in order to target the fourth ventricle. This technique was nicely described by Cinali in 2006, and it was investigated before that aqueductoplasty alone So just opening the Sylvian aqueduct by a Fogatti catheter, for example, does cause a reocclusion in 75% of the cases. That's why we need to leave a catheter behind in order to have a sustainable communication between the CSF in the fourth ventricle and in the supratentorial ventricles. We do a precise planning of the elongation actually of the aqueduct, and this describes us or tells us the entry point at the surface of the calvarium. And here's the video from this case where you can see here the foramen of Monroe, the choroid plexus, and this is already the view in the third ventricle going posteriorly in order to see where's the entrance of the Sylvian aqueduct, which can be seen here. And then we don't use anything else than the catheter, because the catheter is already opening up the Sylvian aqueduct, and it does it correctly if you're using the right trajectory. This is the most important thing. If you have entered the Sylvian aqueduct by the catheter, you can take it away again. So with you pull it back in order to see is the opening in the correct direction, which is the case here, and then you can place the ventricular catheter accordingly. And again, the idea is to have perforation holes at the tip of the catheter, as well as perforation holes in the lateral ventricles, which need to be calculated carefully and then connected to a reservoir. And this is then connected to a shunt system. Most of the patients have a shunt system. I've only seen one patient who came along with a stent alone and did not need a shunt. We've done some investigations. How does this work over a long time? You can see after 2 years, we have a decrease in size in the fourth ventricle, and we have also a decompression of the brainstem, which you can see here, which is longer lasting for after 2 years of investigation. And we looked at the clinical symptoms, and the clinical symptoms, if they were acute, so they lasted lower than 4 weeks before surgery, we could all of them improve or completely resolve. However, the chronic symptoms, which we know on these quite complex patients, cannot be completely solved, but some of them were able to be improved. If you do this in very small children, then you have to think about the fact that actually the head is still growing. And if the head is growing and the catheter is too short, what happens? The catheter tip is ending up in the supratentorial compartment, and the isolated fourth ventricle will again be developing because most of the membranes will close again. So what we have to do is we have to replace the catheter and make it even longer. And this fact is actually correlating with age. So the younger you do those kind of catheters, the more often you have to do a replacement, which can be done, for example, here in this case, with a shunt scope. And here we use an antibiotic impregnated catheter. Here you can see the proximal perforation holes, the distal perforation holes, and this is the shunt scope looking at the tip, out of the tip of the catheter, and then you can go all the way down in the fourth ventricle, and then if you reach the floor, you take your shunt scope away and just leave your catheter behind in order to have the perfect length as long as possible. Multiloculated hydrocephalus is a condition which normally derives from post-hemorrhagic hydrocephalus or post-infectious hydrocephalus, which normally is developing in neonates as a complication. And this is a very bad situation where you have multicystic CSF formations, and all these cysts are actually active producing CSF cysts, so they can grow over time. And the challenge is to connect all of those cysts together to one shunt system. And the most important thing is to avoid multiple shunts, multiple catheters. So our aim is always to have one catheter or either two catheters connected to one Y connector, and then one valve system and one peritoneal catheter. This can be reached if you combine endoscopy with navigation in order to navigate yourself from one cyst to another, but the preoperative planning is very important to have the perfect entry point and then to have two trajectories, for example, to reach as much cysts as possible. This is one example of a patient which we received from another hospital, post-hemorrhagic, post-infectious condition of multiloculated hydrocephalus. Before, 9 surgeries were done, 2 MRIs, 6 CT scans, 36 X-rays before he was transferred in our hospital with 4 catheters. 3 were located here, 1 was located in the posterior fossa. And we were then using navigated endoscopy. And that was basically the solution. After we have cleared the CSF with antibiotic therapy, then we performed this navigated endoscopic procedure. And the only thing we had to do is to enter from above, opening this membrane, opening the septum, and then use 1 catheter, which is then connecting all the cysts. This is already the lower membrane, which you can see here. And if you go further down, you can see here is the catheter, and this is actually the catheter which is here located in the posterior fossa. And finally, we had 1 long catheter with a lot of perforation holes, and then 1 shunt system with 1 valve and a septostomy connecting both sides of the ventricles. It's not always as easy. We have published our experience in 2010. We were able, with the navigated endoscopy, to connect up to 9 cysts in our patients. But often those kind of patients, the earlier you see the problem, the more often you have to do some surgeries. But navigated endoscopy is, in most of the cases, at the end of the line and will do the final solution. The earlier you come and you do surgeries on those, the more dynamic the situation still is. And so you have to perform follow-up MRIs after a couple of months in order to see if more cysts are growing. Now we are looking at hydrocephalus and tumor, which can be sometimes more complex or sometimes less complex. Here's one example of enlarged ventricles due to the fact that there was a hypothalamic hamartoma located in the 3rd ventricle, occluding the CSF pathways towards the posterior portion of the 3rd and the Sylvian aqueduct, as well as the 4th ventricle. And we did a pure endoscopic approach in order to disconnect and remove the hamartoma with a bipolar forceps, and then with a forceps in a piecemeal technique in order to, as you can see here, free the pathway towards the 3rd ventricle, and then solve the problem with the hydrocephalus. In other conditions, hydrocephalus can be caused by tumors. In this case, a 14-year-old with a hemiparesis dominated in the upper extremity. You can see a cystic tumor located in the thalamus with a fluid in the biggest portion of the tumor, but a small solid part in the lower proportion. We did a contralateral navigated approach. Here you can see also already the foramen of Monro. This is the medial wall of the 3rd ventricle on the contralateral side. As we can do the navigation, we can open here the membrane, open the cyst. You can see this yellowish fluid, which is then irrigated. And then in the lower portion in the cyst, you can see the tumor portion, which then can be taken with a piecemeal technique, step by step, and take it out. It was a pilocytic astrocytoma. We left a stent behind in order to have a sustainable CSF connection to the cyst, and the cyst can drain. There was only a limited margin of tumor left, which could be observed. The patient was operated, I think, already like 4 or 5 years ago and did not need any kind of further treatment since then. And the hemiparesis was solved. Another complex situation, which was already shown as similar by Professor Boop yesterday. One day, of birth, after 1 day of birth, a big diagnosis of a huge tumor causing hydrocephalus. And it's two challenges we have: how to deal with the tumor, how to deal with the hydrocephalus. And we normally do an endoscopic biopsy and then put a shunt and then give the patient to neoadjuvant chemotherapy. And if the chemotherapy is working, we can choose for an operation, which we did not do at this step when the patient responded well to chemotherapy. However, after this image, the tumor progressed and we could not do anything for this patient, so this patient died. I just want to mention that we can do intrathecal chemotherapy through the VP shunt by adjusting the valve. You can see a nice distribution of the intrathecal things before it actually reaches the peritoneal cavity. So methotrexate or etoposide can be given by our oncologists. Another situation which is similar: young 3-year-old diffuse intrinsic tumor on the posterior in the cerebellum, but also involving huge portions of the brainstem. So we decided not to do a resection of the tumor. We just did a biopsy in this case. Here you can see just above the posterior commissure, we took a couple of samples. And then it turned out to be a low-grade tumor, actually, with a ganglioglioma component, was taken with LGG chemotherapy. And then you can see a nice response of the chemotherapy, and then some cystic remnants. And then at later stage, we took out this cystic remnant mass in order to treat the patient in a combined fashion as an interdisciplinary approach. Finally, I will talk about endoscopic lavage, which is an additional tool in order to try to avoid any kind of complications. Neuroendoscopic lavage was first introduced by Sergio Caballero. He gave a talk at the Liverpool ISBN meeting in 2007 and called it brainwash at that time. And he did it in intraventricular hemorrhage in neonates. The idea is to use an endoscope to enter the ventricle and then put irrigation inside, let irrigation with the blood remnants go outside and approach the blood to aspirate any kind of blood clots. It can be done in infectious conditions, which we started with already like in 2008 or 2009. And this is one example of a sepsis of staph epidermidis, serratia meningitis, so very horrible case. You can see the snowstorm appearance and all the poos which can be aspirated. Here's one irrigation channel. This is the outflow channel. And then we cleaned up all this poos from the ventricular space. Then we put first a Rickham reservoir. Later, we opened up the cyst and needed to put a shunt. And then we were able to have no further complications with this case. We've published our experience with neuroendoscopic lavage in infectious condition in 2018. We could see that the protein level and the cell count could be diminished by irrigation and lavage. We could see that most of the patients in those conditions needed a shunt. However, 8.7 were without a shunt after neuroendoscopic lavage in the infectious condition. We lowered significantly our shunt revision if we introduced the lavage, and also our reinfection was dramatically taken away compared to our historic cohort where we did not use the lavage. We also started lavage doing an intraventricular hemorrhage in premature babies, which is always done under ultrasound control. Again, you have the irrigation channel here, you have the outflow channel here, withdrawing blood. At the beginning, you only see a foggy, reddish surface. You have to be very still and patient until you see the clots. Then the clots can be approached with the outflow channel, and then gentle aspiration to the outflow channel can reduce the amount of clots as far as possible, but very carefully. And then we do a septostomy, do the same on the contralateral side, and then we decide about putting the shunt later on, but first always doing a Rickham reservoir, which then can be punctured. Our first experience were published in 2014. We could see that the shunt rate was from 100% in our historical cohort to 60%. And we could also diminish the amount of infection and multiloculated hydrocephalus.
Excuse me, Professor Thomas.
In 2018, we published our bigger cohort with 56 patients, and neuroendoscopic lavage led, compared to other techniques of intermittent treatment, to a lower amount infection rate, to a higher amount of arrested hydrocephalus, to a lower mortality, and to lower operative revisions. However, these were only two centers, so hardly comparable to this meta-analysis, which was published by Bativala in 2015. Our outcome is now in press in Journal of Neurosurgery Pediatrics, and we could see that more than 3/4 of our patients were able to walk only with some limited aid, so GMFCS levels of 2 or lower. The Bailey score were similar to the DRIFT trial, which used irrigation by.
Professor Thomas, could you please wind up, please? We are running on time.
Okay, I have to finish.
I'm
already finished. I want to mention.
Sure, thanks.
At the end, our trophy registry, where we are able to actually collect data about post-hemorrhagic hydrocephalus with a number of very distinguished neurosurgeons all over the world. Together with Göttingen, we were able to make an online platform where now already 51 centers from all over the world are joining. And this platform can be reached by trophy-registry.org. It's published in Child's Nervous System to see the study protocol, and everybody is welcome to join this endeavor. So complex hydrocephalus, in conclusion, hydrocephalus is generally a complex disease. In my opinion, complexity is caused by complications which are caused by ourselves, sometimes defined by complexity of treatment. A condition not treatable with standard techniques might be complex. Subjective complexity correlates with training and experience. So see more, do more, and train yourself in order to make all those complex conditions easier for yourself. Thank you very much.
Thank you very much, Professor Thomas. That was a fantastic lecture with all the complexities and the thinking that goes and the strategies and the tactics that to solve these complex cases successfully. There are so many questions on the chat box for you. I think you, if you have another half an hour or an hour, if you would kindly go through on the chat box, type the answers. For a want of a time, I will probably just move to the next talk. But thank you very much. You can see how many questions you have there. Thank you very much.
Thank you very much.
Dr. Komal Prasad, could you please, can I hand the platform to you, thanks? Just a second, I'll unmute you. Dr. Prasad, can you unmute?
Yeah. So the next speaker is Professor Timmappa Hegde. Professor Timmappa Hegde is Senior Consultant Neurosurgeon and Director of Neurosciences at Narayana Health Multispecialty Hospital, Narayana Hrudayalaya Multispecialty Hospital at Bangalore, our place of work. Professor Timmappa Hegde and our team, we were eager to host the 5th INRC International Neurosurgery Resident Course at Mysuru in first week of April this year. Unfortunately, due to this pandemic, we had to cancel the program. Some of you would have registered and even booked your tickets, but due to the unfortunate situation, we had to abandon and postpone the program indefinitely. So partly, Naren, as a compensation for that, he has arranged this meeting, which is beautifully going to utilize this time. And we still have plans to have INRC in a physical sense sometime once all this clears. So apt to this topic, Professor Timappa Hegde will be talking on the COVID-19 situation, how it has affected us and how we should be able to overcome onslaught of COVID-19. Over to you, Professor Timappa Hegde.
Thank you very much, Dr. Naren, for this wonderful opportunity. You've done a great job getting 1,000 neurosurgeons from all over the world sitting at the comfort of their home. Thanks to the chairpersons, Dr. Rajshekhar, Dr. Komal. My brief is very different. We are in the middle of a neurosurgery meet, but we are also going through a pandemic which has affected our lives like never before. We hear a lot of depressing news, and my brief is to see how medical professionals are inspired and are certain that we will be able to overcome, be able to motivate each other, and to be certain that all shall be well. I know I'm speaking to highly motivated people. If you are who you are, being a neurosurgeon, you would have gone through so many obstacles, just like a river is very keen that it has to reach the ocean. And along the way, so many obstacles comes, it has the intelligence to meander through every obstacle. And that is why it is said, when the going gets tough, the tough get going. And it is our time to see a bigger vision for ourselves. When you have a bigger vision, then your ability to overcome greater obstacles, unknown sources of energy come to help you to deal with that. A great source of inspiration for me has been our former President APJ Abdul Kalam, who always tells us to keep your higher vision very clear, and that is what he's called as a dream. A dream is what you would like to accomplish. And he says a dream is not something that you see while sleeping. It is something that does not let you sleep. He would often quote Patanjali from the Yoga Sutras more than some 5,000 years ago, which says that when you are inspired by some great project, by some great purpose, dormant forces and faculties become alive, and you discover yourself to be a greater person by far. Our job is to be inspired. I'll read the quotation for you. When you are inspired by some great purpose, some extraordinary project, your mind transcends limitations, your consciousness expands in every direction, dormant forces and faculties become alive, and you discover yourself to be a greater person by far than you ever thought yourself to be. The wisdom of the ancient Indians are packed in the Upanishads, and the Upanishads speak a lot about training the mind. And they say that it is not really the circumstances that really affect you, it is how much you relate to the circumstances. A lot of this is about mind training, because the mind can be the cause of all our problems. The same mind, when trained properly, can be the source of freedom. One of the greatest minds from India, Gautama Buddha, had this to say. He says, watch your thoughts. Are you entertaining inspired thoughts, or are you having depressed thoughts? He says, watch your thoughts, because they become your words. Watch your words, they become your actions. Watch your actions, which you do repeatedly, become your habits. Watch your habits, it becomes your character. Watch your character, that leads to your destiny. And then he makes a landmark statement: change your thoughts, change your destiny. As this statement is so remarkable, I would like to recall these words again. He says, watch your thoughts, they become your words. Watch your words, they become your actions. Watch your actions, they become your habits. Watch your habits, they become your character. Watch your character, for it becomes your destiny. And if you're able to change your thoughts, we are able to change the whole course of our life. This was amply displayed by Viktor Frankl in his observations when he went through intense suffering in the concentration camps. And being a great and a highly qualified psychiatrist that he was, what he observed that the situation is the same, but among his fellow prisoners, different people reacted differently to the situation. Even those who were not so physically strong survived all the ordeals of the concentration camp simply because they had a certain mental flexibility, a change in a certain mental attitude. And this is what he had to say. Everything can be taken from a man, but one thing, the last of the human freedom, is to choose one's reaction to a given set of circumstances. And once the war was over, he put his thoughts in a form of a book, which is called Man's Search for Meaning, which laid the foundation for a new school of psychotherapy called logotherapy. Logotherapy essentially means, can I discover meaning? Can I discover why the whole world is going through this? And if I'm able to find meaning, if I'm able to discover purpose, my ability to handle difficult moments become much easier. Our primary job now is to be able to be inspired and to be working in a hospital, which is really not the safe place to be in, especially in countries like ours, which has not seen the worst of this pandemic. We are still going through the upward trend, and we always have a feeling that we do not know which patient might be the one who might infect us. Throughout our working time, we are in so much layers of protective equipment, which is not very comfortable. And therefore, these are certain things that I would share with my fellow colleagues of how to be inspired. When I'm in hospital, we are so much more fortunate that we are the therapists and not in the hospital as a patient. Whenever you feel blessed, you are always happy. You can never be grateful and miserable at the same time. And therefore, if you can inspire yourself that I'm so blessed to be more on the treating side than as a patient or a family member. The second is, while I am well, let me make the most of my life. And these are certain opportunities, especially when there was a complete lockdown, when so many of us had very little to do, to reflect on what is the meaning of life and what is the purpose of life. I would refer you to a very inspirational talk by Brother David Steen Rast, who asked this question: is it happy people who are grateful, or is it grateful people who are happy? And he deduces very well that whenever you are grateful, you are happy. And what do we want in life? All that we want is to be happy. And he brings us to reflect on something very important. What is the greatest gift all of us have in life? And the greatest gift, a gift is something that has been given to us free. We have not paid for it, we have not asked for it. And the greatest gift that we have is this moment. If we can appreciate the gift of this moment and all our abilities to make the most of this moment, and we miss this moment because either we are regretting something that has happened in the past, or we are wondering about what do I do next, and I miss the glory of the moment. True life happens in this moment. Part of mind training has been very nicely brought out in a book by Hermann Hesse, the German who won a Nobel Prize for one of this, possibly for this book itself, called Siddhartha, where the character trains himself to be extremely tough. And you will be surprised to two simple things. I can fast. I can fast means I can do without food and water for an extended period of time. Now, if you can train yourself, that brings about a tremendous amount of mental resilience. The other mental training that you can do is I can wait. And if I want something important, I can wait. I can wait indefinitely. If we have these two characteristics, that brings about a lot of mental fitness and a lot of mental flexibility, and really no obstacle can be an obstacle for you. It is possible through mental training to be able to overcome any obstacle. Children in hospital always see us as the cause of all their pain and cause of all their suffering. Here's a little boy who's waiting for his turn for a surgery. And this is not what we normally do. We allow the mother to come into the operating room. The anesthetist would very gently anesthetize on the lap of the mother. But for dramatic reasons, I just showed the moment we take the mother from the child is going to cry. The child is not able to realize that the child is actually going in for a healing process. When we go through difficulty, our mind is like the little child. We are not able to see the whole picture. And to see the whole picture, this is the limitations of the human mind. Albert Einstein, one of the greatest scientists of the world, is reported to have said in his autobiography, when I started my scientific discoveries, I was confident I could demystify the universe. And today, in the evening of my life, one thing is very clear: the mystery has only deepened. The more I know how little I know. And this is one of his quotations. It goes like this: the deeper I went into existence, the more the mystery deepened. I'm dying full of wonder. I'm dying in wonder. And if this is what the greatest of scientists could say, if I'm not able to understand why I'm going through a certain unit of difficulty, I would say be patient. Time will tell you a greater picture. This is an inspirational thought from Dag Hammarskjöld, a Swedish economist, a Nobel Prize winner, and a former Secretary General of the United Nations. And he had this to say: for all that has been in my life, especially the difficult moments in my life, can I be able to say thank you? And for all that shall be, yes. I repeat, for all that has been, thanks. And for all that shall be, yes. This is a line which I've been greatly impressed, and I find it very relevant at this time. This is a quotation from the Bhagavad Gita, where Krishna tells Arjuna, he's preparing Arjuna for the battle. And he's telling him that happiness and sadness, good times and bad times come and go. Nothing is permanent. And if you have to handle the battle of life, you have to be mentally strong. This is a poem from another Nobel Prize winning poet from India, Rabindranath Tagore, who had this to say: let me not pray to be sheltered from dangers, but to be fearless in facing them. Let me not beg for the stilling of my pain, but for the heart to conquer it. Let me not look for allies in life's battlefield, but to my own strength. Grant that I may not be a coward feeling your mercy in my successes alone, but let me find the grasp of your hand in my failure. Finally, I would like to say, is it possible to be mentally tough and yet flexible? I have used this quotation from the Alcoholic Anonymous, which goes this way: grant me the serenity to accept things I cannot change, courage to change the things I can, and the wisdom to know the difference. I conclude with the story from King Solomon. King Solomon told a man that I've heard about a fabulous ring with unique power. When a sad man gazes upon it, he becomes happy. And when a happy man gazes upon it, he becomes sad. Find that ring and bring it to me. The man set out in search for the ring, but no one had ever heard of such a ring. He was about to give up when he spotted a junk dealer. He approached the owner and described the object of his search. A ring that cheers the sad and saddens the cheerful, said the junk dealer. Come inside. They entered the shop, and from a box full of old rings, he took a plain silver ring. He engraved some words on it and gave it to him. The man read the inscription and headed back to the palace. King Solomon read the inscription and laughed. And he says, this reminded me of the wealth and power that are fleeting things. King Solomon removed all his costly rings and slipped on this ring that he got from the junk shop. The phrase engraved on it was, this too shall pass. This too shall pass. Thank you very much.
Thank you very much, Dr. Timaba Hegde. This is a very timely talk for inspiring and for us to face the challenges. And I don't, as you mentioned, this is not a challenge that is necessarily transitory, and we will have ups and downs, and your wise words are something to inspire us and guide us as we go through the coming days, months, and maybe years. So thank you very much. And I really look forward to having the International Neurosurgery Resident Course in Bangalore or in Mysore, hosted by yourself and Dr. Kumar Prasad. The thing is that as much as these webinars are absolutely fantastic, we are learning lots of things. We can do it from our home. I think there's something about meeting people, meeting your peers person to person, meeting the experts person to person, that inspires. There's the education is multi-layered. There's facts, figures, there's inspiration, and there's some touch of greatness that's transmitted. So as much as I love the webinar, I think it's fantastic, but nothing like also having a real course that we meet up. I hope that will be next time with you. Thank you very much. And we will close this session, and I'll thank Dr. Kumar Prasad and all the speakers for this fantastic session. and we will meet again in 25 minutes for another fabulous program that we have. The next session has Professor Diopujari, the eminent Indian neurosurgeon and former president of the ISPN on craniopharyngiomas, Professor Moroto from Japan, who's a world-class neurosurgeon as well as neurophysiologist. He will be talking, and then Dr. Anna Mazzio on the important aspects of brain death, and Dr. Risk from Pennsylvania, from Hershey, on the dilemmas of managing arachnoid cysts, and Dr. Roth from Israel on cranioplasty and syrinx. So I look forward to seeing you again in 25 minutes. Please stretch your leg and take some break. Thank you very much again. Thank you, Dr. Hackett.